It's the Hear Me Now podcast. I'm Sean Collins. In August, the New England Journal of Medicine published a paper titled Hospital Standards of Care for People with Substance Use Disorder. In it, the authors note that more than 100,000 Americans died from drug overdoses in 2021. It's a staggering statistic. They write, the United States is in the throes of a decades-long exacerbation of drug-related harm. Hospitals are a key domain for implementing person-first, evidence-based interventions for reducing that harm. Yet, despite the obvious need, hospitals have been slow to enact reforms to improve the health of people who use drugs. Dr. Honora Englander and attorney Corey Davis wrote that piece, and they join me now. Welcome to the podcast. So glad you're here.
Thanks so much for having us.
Yeah, great to be here.
Your paper reminds me a little bit of the Declaration of Independence, insofar as it's a long litany indicting the king and the status quo, and then at the very end it offers a vision for reform and hope. And I want to get to that vision of a new approach, but I think we have to start where you started, and that's how things are now. What's wrong with the way people who use drugs are cared for in hospitals?
There are no incentives, there are no quality measures or financial incentives or otherwise for hospitals to work towards reform and work towards change. And undoubtedly, hospitals have skin in the game in this. There are enormous numbers of patients who are hospitalized with medical and surgical complications of their substance use disorder, and patients have poor outcomes, they have negative experiences, they're often mistreated, and there are real harms as we describe. There's also missed opportunities in terms of we have effective care for people who struggle with substance use disorders. Some of that is helping reduce the harms of use. Some of that is offering people evidence-based treatment that can be life-saving treatment. So we have a whole array of tools that right now are not offered in most U.S. hospitals. And to change that, there are pockets where there are highly motivated clinicians. There are, physicians who are working towards change, nurses, pharmacists, others, and I have the real privilege of working with them around Oregon and around the country. However, without clear and stronger incentives that extend beyond individual hospitals and beyond individual hospital systems, I don't think that as a country we're going to be able to make a change. And there really is sort of a scientific and moral and ethical mandate that we do that and that we do that now.
Yeah, I don't want to overly simplify it. So let me just go ahead and overly simplify it in this question. If there isn't a return on investment that's obvious upfront, it seems like it might be hard to make change in some healthcare settings.
I would agree wholeheartedly. And I would also say that there are ways to change the conversation such that from an individual hospital administrator's lens, if we reimburse differently, if we restructure differently and start to incentivize change, there may be a business case that is clearer and more accessible from the individual hospital lens. As we look at a societal lens, there of course is a very important quality and financial case to do this, but the way that it's structured currently is setting us up to fail.
I think bringing it back a little bit, hospitals are just microcosms of the rest of America in a sense, right? And so we primarily, we have evolved this system whereby people who use drugs are primarily criminalized, stigmatized. Addiction is often viewed primarily as a moral failure, even among many clinicians. And hospitals reflect that, right? So just on a practical level, you show up at the hospital, you may have clinicians who are looking down on you, who you can, just kind of feel that psychologically. It can also be reflected in the type of care that you receive. As we write in the article, a lot of hospitals, their actual, stated policy they follow is to basically dehumanize people who show up with a condition, even if it's not related to their addiction, right? You fall down, you're in the ED, but it's in your medical record that you know, have a substance use disorder. Your belongings may be searched. You know, you may not be permitted to have visitors. You know, all of these ways that make it so you don't even want to go to the hospital in the first place. It's not a welcoming place. Um, you know, and that's absent from. I mean, that's you know, related but separate from all of the financial incentives and so on that we're talking about. And those, you know, in some sense reflect, you know, they're both products of and causes of the way that people, you know, treat patients and the way that patients perceive the experience. So I don't know. It's both complicated and not, right? I mean, you know, the system wasn't always set up that way. You know, the sort of we've grown up with this sort of war on drugs mentality. So it's been the water in which we swim for so long that we sometimes, I think, kind of think of it as inevitable, or the way that things are always going to be. But it's not the way things have always been. You know, it was. This is actually relatively recent, and it's possible to change it.
I'll just add, and I agree wholeheartedly with Corey, and I also think that there's a way that, and we see this all the time, individual stigma perpetuates and propagates structural stigma. And by structural stigma, what I mean is, you know, the absence of trauma-informed and evidence-based policies. I mean, the absence of prepared clinicians. I mean, you know, no pathways from hospital to community care. All of these system-level gaps, including the policy and financing gaps, but those are perpetuated and propagated by individual stigma. And then it's a sort of reinforcing loop that without those policies in place, without those systems in place, clinicians feel an enormous amount of moral distress. There's mutual mistrust between patients and their providers in the hospital, and that then worsens the cycle. So again, we've seen in our own experience integrating addiction care as part of our consult service at OHSU that we can disrupt that in many ways.
Mm-hmm.
And to make widespread systemic change across US hospitals, we really need to invest not only at the individual or sort of individual hospital, individual clinician or individual hospital level, but at a policy level.
Let's talk about those interruptions and the successes that you're seeing. But can I just ask one clarifying question? Are we talking about both individuals who have substance use disorder who land in the hospital because of their substance use disorder, and people who have substance use disorder who land in the hospital for some other, perhaps unrelated ailment, and their substance use is either ignored or downplayed once they step inside the hospital?
I would say both. And I would also say that, you know, the focus of our piece, and I think the sort of most concerning experience, is people with an active substance use disorder. But I also care for patients for whom they've had years of recovery, who may be denied certain surgical or medical procedures because of a medication that they're on, like methadone or buprenorphine, which are life-saving medications that are stabilizing and supportive. So again, we're talking really across the spectrum in terms of what people experience, you know, and again, referencing what Corey was saying too, you know, I talk to patients and I talk to other friends and family who describe the very common experience of people being really afraid to go to the hospital for fear that they'll be mistreated. And we simply can't have that. Instead, we need the hospital and health systems to be a place where people can come and express their needs and get the support and care that they need.
Yeah. I mean, it really does speak to the lack of trauma-informed care if people are afraid to get help that they know they need.
Mm-hmm. And often they're not wrong. I mean, you know, they're not wrong to fear that they will experience stigma or discrimination.
Yeah.
You know, there's a third category of, you know, people who, and I think Dr. Englander is really getting at this, you know, folks, you know, not whose substance use disorder is ignored, but people who may not feel that they have and may not have a substance use disorder, but who show up in the hospital for something else. And the clinical staff assume that the problem is that this person has a substance use disorder and treat them accordingly, and maybe don't probe enough into like, well, is this actually, primarily something else or something else? And just jump to, oh, well, this is a frequent flyer, this is an addict, and therefore we can discount anything they say and any other needs they might have. So that's kind of like a third,
Right.
Separate but related
Right.
category.
How could it be better?
There's so many ways that it could be better. And, I think that there are, again, these pockets of examples really across very diverse clinical settings in large academic medical centers that may have addiction consult services, to emerging work in some of the small rural hospitals that I have the real privilege of working with. But one of the things that I think we see is that having prepared teams, having, being able to offer people evidence-based treatment such that we can treat their withdrawal, we can manage their pain, we can talk about cravings, we can, again, just really provide those necessary supports and care, that treatment changes culture. And we've done some work at OHSU interviewing interprofessional hospital staff and asking about their experiences before and after our care team, which is called Impact, or the Improving Addiction Care Team, before and after Impact. And, the stories are remarkable. And again, we're far from perfect and we have a long way to go. And, there's really important differences. And clinicians, that moral distress that I described, where clinicians just feel so sort of frustrated and there's this sense of futility, that's not inevitable. And that can change. And many of the people that I work with now describe that their most satisfying patient encounters are working with folks who have substance use disorders. So again, I think it's not inevitable, and the climate currently does not support the best care from happening. It's more the exception than the rule.
It would seem that having an eye towards life after discharge would be crucial, that you're constantly planning during a hospitalization for what life is going to be like after you've left the hospital.
Yes. And I guess what I would say is that in terms of the work that we do, our team is our consult service team is a hospital-based team. And so much of what we're doing is supporting people through that hospital care to receive the care that they need while they're in the hospital. And then we also support people around initiating treatment, connecting to care after, reducing the harms of their use. So there's a focus on kind of meeting people's needs during hospitalization and after. I think that sort of post-acute care transition is also a huge area for improvement. There's some sort of really great emerging work around that. And again, just massive gaps in terms of how we address this broadly.
Corey, what do you see as ways to improve things?
Yeah, I think there are a lot of possibilities. Like you were getting at, incentives matter, right? We would like to think that everybody is going to do the right thing because it's the right thing, but in the U.S., more so than most other places, healthcare is driven by the profit motive, right? Even nonprofit hospitals, are out to make money, and partly because of the stigma and criminalization that has attached to substance use disorder over time. A lot of treatment for people with substance use disorder is poorly reimbursed or difficult to get reimbursed at all. So we could change that, right? We know from other things that particularly the federal government has done to change the way care is reimbursed. If you want hospitals to provide different and hopefully better care, you can incentivize that by paying for it, and it does change practice. So that's one part. I really do appreciate what Dr. Englander was saying about how just clinicians' practice can change by changing clinician practice. Can change attitudes, which makes a practice better, which then sort of diffuses out. If it's an academic hospital, that's going to, sort of diffuse into the trainees and so on. So I think that's really important. We could, CMS pays for most residency training slots in this country. CMS could require that all residents receive at least a minimum amount of evidence-based training in how to treat and prevent substance use disorder, which they currently don't. You can graduate medical school, go through residency, go through fellowship, and never have real formal training in substance use disorder care and treatment, which is bananas, given that it's, as we said, over 100,000 people a year are dying. So, there are lots of there are lots of ways to change things.
We're talking about how people who use drugs are cared for in hospitals with attorney Corey Davis, who directs the Harm Reduction Legal Project at the Network for Public Health Law. He's joining us from Los Angeles, and we're trying hard, Corey, to make your line sound better. Honora Englander is professor of medicine in the Division of General Internal Medicine section of Addiction Medicine and the Division of Hospital Medicine at the Oregon Health and Science University in Portland. I want to go back to the issue of stigma for a bit. It feels like it's an immutable force in our society and hard to escape, but it would also seem that it has to be part of the training that caregivers receive, that patients are worthy of care and respect regardless of how they present.
I think it's partly about training, but again, I think it's really partly about system preparedness. And I think we could, and so, part of what we've done with our team is we've integrated peers who have lived experience with addiction and lived experience in recovery as part of our care team. And, peers offer enormous supports to patients who really build trust based on that shared lived experience. And then they transfer that trust to clinicians who may not have, who have a very different relationship and often a very different agenda. So they really sort of serve as a cultural broker within our care team. And I think peers, we have students and residents and faculty who learn from our peers in ways that are different than the ways in which they learn from me or other physicians on my team or the social workers and nurses and pharmacists on my team, who all really bring a unique perspective. I don't know. I think it's partly training. I don't think it's immutable. I think it's actually quite changeable.
Mm-hmm.
And it's partly by seeing how it's the language that we use when we talk about addiction. It's the assumptions that we make about what people deserve and what quality care looks like. And it's about challenging one another in the space. But I don't think it's just about training, and I definitely don't think that it's immutable.
Look, I'm not a clinician. I was raised by two of them, but I've never worked a day of my life in a hospital setting or in a clinic. But I've been a patient, and I've witnessed a kind of attitude that you run into. I've noticed it in emergency departments and in some surgical settings where there's a sort of gruff behavior exhibited by caregivers. Corey, earlier you used the language of frequent flyers and the way that people are dismissed in some settings. I've seen that happen where you treat people as kind of a problem that you have to deal with, and I wonder about that culture among some caregivers where there's this sort of assessment made where this person isn't worth my time in the same way that some other people might be worth my time.
Yes, I mean, I think about this a lot. I dabble in academia, right? There's this common trope at the end of an academic article. You always say, well, more research is needed, and I'm always the one who's like, well, a lot of this stuff is actually pretty straightforward. We actually don't, we know a lot of what works. for people with substance use disorder. But I actually think that this is an area where more research is needed. How do we change those hearts and minds? And it's tough. I mean, so I was an EMT, right? So pre-hospital care, but you end up hanging around in EDs a lot. And my experience there was that the leadership and the mentorship really does matter. You know, as an EMT, you're on the bottom end of the totem pole, right? So if the paramedic or whoever it is, the officer that you're assigned to, if they are approaching the patients as like these, this is a person who is deserving of dignity and respect, and we're going to try and help them as best we can, with the tools that we have available to us. Like, that's the way the team works, and if the person is like, I signed up to be a firefighter and I don't want to be on the ambulance in the first place, and I don't really like these people and I don't like dealing with them and I just want to, get rid of them as soon as I can. Well, that's the way the team is going to work. I think the question is, how do you have the first kind and not the second kind? Some of that is recruitment, I believe. I mean, I think that's really complicated. I think the question of how do you get a more diverse group of people to be physicians is much more complicated. It's a lot easier to solve for that problem on some levels where you're hiring EMTs as opposed to physicians. But I think that question of how do we change the beliefs and the way that clinicians approach their patients in general, I think there's not enough good research on that. And my like I said, my personal sense is that just the role of that. I don't know if mentorship is exactly the right word, but just observation of what the higher status people in the organization are doing. And some of that can be formalized, and you can and should make regulations and policies that enforce the kind of behavior that you want to see. But so much of it is just you learn by doing. I mean, that is a lot of medical training. Has that as explicit. So it's so important to have good clinicians. How to build them in the first place, I think we don't know enough about.
I think that's right. And I think, in particular, as it relates to care of people with substance use disorder, and then particularly in hospital settings, I think there are some challenges that are not surprising, but really helpful to name. And I find myself bringing this up in various contexts. It may be that I'm working with a hospitalist who's struggling about someone's active use in the hospital, and I'm trying to kind of coach them through managing that situation. Or it may be that I'm in a meeting with, larger groups and trying to reshape policy. But I think there's a really lovely piece. I'm gonna get the name perhaps incorrect, but about a clash between harm reduction and medical culture. And Chinazo Cunningham, Dr. Chinazo Cunningham, who's someone I admire tremendously, is the senior author on that piece. And they really describe how the medical model clashes with a harm reduction model. And a harm reduction model at its core really acknowledges and appreciates the individual as the expert in their own life experience. And a biomedical model is all about hierarchy and control. And I think so much of the conflicts that we experience in hospitals are around that core issue of who's in charge, who has the control. And that's a very unsettling kind of piece that's at play, again, at an individual clinician and hospital system level. And then you sort of add these external challenges of the way that we approach drugs and drug use in this country. And it's no wonder that the problems are so they're deep. But I think for me, recognizing that tension and clash between the harm reduction model and the biomedical model, in particular in hospitals, is really important. I will say that, again, thinking back to the role of peers as part of clinical teams and also changing systems, we've done some work around integrating peers into hospitals, and it is hard work that requires a lot of, I think, really a lot of consideration.
Yeah.
And it's hard for peers, it's hard for systems, and it's just extremely valuable work. And part of what peers can do is show us the ways in which hospitals don't hear our patients. It can change the power structure in a really important way.
I also think, it's important to get the right peers. I mean, you have a lot of people who come from sort of the 12-step model and, you know what worked for them. And this is not, this is universal, right? Everybody thinks on some level that my experience is universal and what worked for me, should work for you. And if it's not, the problem is you. Not that we're all different. But just, I think it's kind of a similar thing, doing a good job of knowing the kinds of people that you're looking for, and hiring those people. It's not enough necessarily to someone. There are lots of people who have are in recovery from substance use disorder who have the same kind of internalized stigma that other people have, and that's not super helpful.
Yeah.
Absolutely. And I would agree with that completely and say that, again, kind of without infrastructure, hospitals are intense places. And, supporting peers to be most effective, hiring for the right peers, and then supporting them to be the most effective is, again, another huge space where we don't have enough experience.
Yeah. I think one takeaway has to be, almost in any environment where there's a hierarchical mentorship going on, never to downplay the importance of a mentor glaring at someone and saying, we don't treat people that way. One intervention that's as simple as that can change the way people start to behave in an environment where they're learning. I mean, I've witnessed that in a newsroom.
Yeah, I agree with that. I mean, I don't want to overplay that. I mean, I do think that other incentives matter and so on. But yeah, I mean, I definitely agree with that. I mean, some of that is just just the leadership. You see how their supervisors, the people you're supposed to be learning from, act, and you internalize that either because you just think that that's the way it should be, or because you're promotion and your happiness in the workplace depends on you pleasing the people that you report to. But I agree with that. I mean, I think that in some of the more egregious non-clinical things, like we talked about in the article about how it really is the case that a lot of hospitals have explicit policies to discriminate against people who have substance use disorder or using drugs, to really, dehumanize them,
Yeah.
To treat them not only differently, but worse than other patients in the same hospital. I mean, that's policy. Like, you can change that. Either administrators, physician leaders, nurse leaders. I mean, nurses have an enormous amount of sway in how the actual hospital operates. And that can be changed through changing policies and procedures and the wagging of the finger. It's both.
It's much more than bad behavior. Again, it's these reinforcing system-wide gaps. And some of the bad behaviors are a result of those. There are many, many hospitals that have people are not allowed to leave there to go smoke. And for some people, a cigarette is what allows them to stay in the hospital. And of course, there are health harms from smoking cigarettes. And, we sort of often, I think, in particular around people's substance use, where, again, the system does not acknowledge that people are maybe using drugs to self-manage a lot of other distress. And so we strip away those coping mechanisms and we don't offer any replacement. and we then punish people for the inevitable consequence of that. It's just really, again, a very layered, and I think there are some really concrete things that we can do differently, without an act of Congress or with an act of Congress, but that we can do and need to do.
Yeah. How is your piece has been out for a little over a month, I think now. How has it been received? What are you hearing from your colleagues?
I've had really lovely reception across. Nobody's reached out to me with any negative comments, and instead, the CEO of my hospital sent an email sort of saying, I hope that we're doing everything that we can do here. I'm working with, there's been, and that's of course at just one hospital. And there are ways that we can improve in my hospital and in our health system. But then more broadly, I've actually not connected with policymakers yet, and hope to, and have sent it to some of them, and kind of hoping to move that forward. But from lay people and clinicians and hospital administrators, I've had a lot of really positive feedback. So really hoping to engage, again, that next level.
Some of this stuff is really hard. Some of it is complicated, but some of it isn't, right? There is a lot of stuff that is so basic, so clearly wrong, and relatively easily changed. So that's my hope, is that we'll see, in some little way, this paper will help nudge policymakers in the right direction.
Yeah.
The other thing I feel like saying, is just that I think by investing in focused work to improve population health for hospitalized people with substance use disorder, we can raise the bar for everyone. I think what you're describing of that experience, being frightened in an ED or an operating room and not sort of feeling like you as an individual matter, is someone, that, again, I don't want to draw too much from what you're saying, but that's an experience that anyone can have regardless of whether or not they have a substance use disorder.
Yeah.
And I think by improving systems for our most vulnerable patients who are systemically marginalized through all of these systems, we can make care better for everybody.
Right.
We train better, we build better systems, we train better staff, we have better culture. That does raise the bar for everyone. So again, I think it's not the primary argument or reason that you do this work, but I think it's a potential side effect that's a very welcome one.
Yeah.
Because that dehumanization, that harms everyone in a way.
Yeah, absolutely. Absolutely. And the fact that it feeds back into how you practice the next time around with the next patient, that it does create this feedback loop of, I'm going to decide at the outset of the encounter whether I like this person or not, and whether they're deserving of my best care and all of me being present to them.
Yeah, and we could talk about this forever. I mean, we didn't, like clinician burnout is a real thing. I mean, it is, whatever. Obviously, physicians, occupy a very privileged place in society. And it is also the case that it can be very difficult to be a physician. You're being asked to do a million things and you don't have any time to do any of them, right? And it's a lot easier. I mean, some patients, I don't want to put this in a way that sounds like it's blaming, because I don't mean it that way, but like people with substance use disorder sometimes need a lot of complicated care. Like it can be hard to work with them. And I don't mean that in a blaming way. I just mean like sometimes you've got a lot of stuff going on, and they're just not only literally the resources, but you just don't have the time. Like even if you want to, spend a lot of time with this patient, really figure out, what are all of the things that you need help with? How can I connect you? Like, you literally do not have time to do that. Like, it is literally, there's just, the time is just not there. You need to move on. So that, again, like I said, this is like a microcosm of, of all of the other problems that exist. And, that's not specific to opioid use disorder or substance use disorder. That's true of a lot of patients. But So some sort of systemic reform. I mean, obviously, population health reform is necessary, but just even in the hospital context, giving more thought to how can we try to treat the whole patient, follow them throughout their disease course, throughout the life course, as opposed to just like, what are the DRGs for this patient and how can I get them out of my little little silo and either out of the hospital or into somebody else's silo. I mean, that is not specific to substance use disorder, but it definitely doesn't help. And it's it can, the system is not designed to encourage oftentimes, empathetic, understanding care. Even if you want to provide that, again, I'm not trying to make excuses or whatever, but it's hard.
Well, it's hard, and the policies make it worse. The conflicts that staff experience because they don't have the training, or they, or the policies are bad. Those conflicts are sometimes what our team spends the most time addressing. It's not the conversation at the bedside about how do we support you on your craving or your pain or your withdrawal that takes that's the sort of the angst or the distress. It's those conflicts, and those conflicts, again, the system is largely contributing to those conflicts, and it's those control battles that I think are often unnecessary and avoidable.
I think you've given people lots to think about, and almost a blueprint of how you could go forward. So congratulations on that.
Yeah, thank you. Thanks for having us on.
Thanks a lot. It was fun.
Corey Davis directs the Harm Reduction Legal Project at the Network for Public Health Law. He was speaking with us from Los Angeles. Honora Englander is professor of medicine, Division of General Internal Medicine, section of Addiction Medicine, and the Division of Hospital Medicine at the Oregon Health and Science University in Portland. Their paper, Hospital Standards of Care for People with Substance Use Disorder, was published August 25th in the New England Journal of Medicine. You'll find a link to it on our website, hearmenowpodcast.org. Heads up, if you don't have institutional access, know that the paper is behind a paywall. But if you register for a free NEJM account, you'll get access to 2 subscriber-only articles each month, plus whatever the editors put in front of the paywall. The Hear Me Now podcast is a production of the Providence Institute for Human Caring, on the web at hearmenowpodcast.org. The program is produced by Melody Fawcett and Scott Acord. We have absolutely invaluable research help from medical librarians Carrie Grinstead, Seema Bhakta, Amanda Schwartz, and Heather Martin. Our theme music was written by Roger Neal. The executive producer is Michael Drummond. I'm Sean Collins. Thanks for listening. Our next program is coming to you in 3 weeks. Until then, be well.